how to bring this science of molecular biology, genetics, and all the variants that we talk about. How do we bring this into clinical practice? That is what we are all about. And why do we need this? If you go to the next slide. So this is why we are here. So this is the data from August 17, 2022. So this is global research which is going on in terms of chronic medical conditions across the globe. There are 767 medicines which are in phase 1, phase 2, phase 3 trials, which are actively being researched. And people need to understand this part very well, because whether we are ready or not, this is going to come. We better be ready when the personalized treatments are going to hit the medicine anytime soon. If you look at the conditions, there are 300 trials only for cancers and 94 trials in cardiovascular medicine and 64 medicines which are on a trial for diabetes and obesity and 166 medicines are in phase 3 trial. And not all of these are actually receptor-based medications. Most of these are targeted therapies. So this is the reason why we should try to adapt to personalized medicine as early as we can, because no matter what, the convergence between genomic medicine and clinical medicine is happening, and it is going to happen sooner than later. And Dr. Hima will talk about personalized medicine and what it is.
The genomic medicine, the genomics is being fast adapted into clinical medicine. You just looked at the number of drugs which are already in the trial. Cardiology and oncology has already been using targeted therapies for a while. So I think among all the physicians, probably oncologists are the most well-versed with using genomics into personalized medicine. But having said that, you already saw in cardiology, there are about 90 plus drugs which are already in trial. And diabetes is also not far behind, which means the rest of us, all of the medicine subspecialties also have to start picking it up. I recently, if you guys have heard, inclisiran just got approved for cholesterol, which is basically a PCSK9 inhibitor. The drug itself, inclisiran, is an siRNA, and it binds to the mRNA of PCSK9 and reduces the PCSK9 levels, so LDL levels get reduced, right? So that's the first one which has already been approved. 3 more are in pipeline. So it's high time that we start adapting as well. So one of the reasons we wanted to do this was we have been, when I went to Harvard Med School, that was in 2015, it was just the beginning. That's when we were just having the clinical rotations. It was quite exciting to go through that. But now they have also introduced it into residencies. The drugs are coming out. So the problem that we have mainly is in our medical curriculum, we don't have a lot of genomics. And there is a whole lot of scientific community who are actually working on this field. There needs to be a binding between the two of us. Otherwise, we won't be able to deliver this to the patients. So that's the whole point of introducing this concept of personalized medicine. Bottom line, personalized medicine is nothing but treating the patient according to something which is tailored for the patient. That includes genomics as one of the ammunition. So integrative medicine and precision medicine, the reason we put up there are they're kind of used synonymous with the personalized medicine. And the reason, first of all, why personalized medicine came into being, I'm pretty sure there are a lot of physicians here. You must have faced this situation as well. Your patients just keep coming back. You start them on a drug. They don't respond well. You put them on polypharmacy. Still no response. Maybe some side effects. It gets frustrating for the physicians. The medicine has been evolving in the last 50 years, yes. There are a lot of advanced technologies coming in. We are all able to use all of that. But still there is something which is missing. We are not able to tailor it exactly for the patient. And that gets quite annoying for the treating physician. And not just that, so this is the treatment failures. Can we go to the next slide, please? So this number was quite appalling for me. If you look at that, almost 50% of the treatment prescriptions that we give out are not really working. They keep coming back for management again and again. So, and as if this is not enough, so yeah, one size doesn't fit all. That's what we're going to talk about. And if this is not enough, there is another aspect to it. There are no clear, concrete, scientific preventive guidelines which are available for physicians as well. So people just do whatever they feel like, all these Atkins, whatever fat diets people come up with, no carbohydrates or no fats or excessive protein and whatnot. Now that leads to another set of problems. They end up with renal failure, cardiac failure. I'm pretty sure you must have seen those as well. And patients vouch with that. So we need something which is very scientifically based as well for the patient. So it's a complete 360, involvement of the patient care, not just the treatment part. The physician is able to take care of the screening, the diagnostic protocols, and the treatment with the biomarker-based drugs. But also there is something for in terms of the diet, the lifestyle as well, which is actually becoming one of the major issues these days. Can we move? So these are the 4 P's of medicine. These are being adopted worldwide by all of the major governing medical bodies. So the point is to try to make the treatment management as personalized as possible, also involve predictive and preventive aspect to it, and make sure we are involving the patient as much as possible as well in the management. So these are some of the major associations which have already been, strongly advocating genomics, personalized medicine. Some of them have also been looking at alternative medicine to add as an adjunct to the traditional practice. But since we need some kind of objective evidence, genomics comes into play. We keep moving on. So I'll just hover on this for a second. In our medical field, this is how it's being adapted right now. This is the situation of personalized medicine in our medical field currently. So initially, I think when we all were in med school, you guys probably remember the Mendelian genetics still being used in pediatrics quite frequently. Okay, I need that slide. So anyways, while they're putting up that slide, let's keep talking. So moving forward from Mendelian genetics, there has been a drive to figure out the human genome, which was deciphered in 2003. That's when all these popular bigwigs got it done, and it was costing billions of dollars. Following that, now that we figured out the human genome, they wanted to know what each variant is responsible for. There are a lot of scientists here as well. So you probably have heard of the genome-wide association studies wherein, which variant INS is for diabetes, which RSIs are involved. So those studies were done. Now finally, so by 2019, now we have quite a lot of evidence. Like I said, when I did clinical rotation at Harvard, I was still one of the newbie, physicians didn't know a lot. We were just getting to know a little bit of, Crohn's disease, this, that. There was no structured curriculum at all. But by 2019, already ACGMEM, part of their body, the American College of Graduate Medical Education, now we have residency programs which have genomics as one of the core curriculum. So instead of 3 years of internal medicine, now they do it for 4 years. They have it in gynecology, pediatrics as well. So, which means the physicians right off the bat are well versed with genomics and can practice personalized medicine. Now that's with the teaching part. Then if you look at the regulatory guidelines, ACMG is American College of Medical Genomics, which governs all of the ethical guidelines and how you're supposed to analyze the genome sequencing to be done. So all the regulatory guidelines are mandated by the ACMG. So those have been started to come into picture, and FDA has now started to approve the genomic variants databases, which can now be used by physicians for public use. So that has, and that's why the health insurance providers have also started reimbursing that. Now moving forward to the next one, which is the most important one, the drug prescriptions. Like I said, inclisiran is just the first one which came out for cholesterol for us internal medicine specialists, so we are excited. Oncologists are probably like, we already know about this. But then a lot of drugs are coming in already, which are going to be biomarker based, which is basically gene based. Now, that's up till now. Now it's going to just boom because just now Jayesh Ranjanji just told us that they are going to take this initiative of genomic excellence. Pretty much all across the world, this is going on. So there's going to be a lot of sequencing done, and all of that evidence is going to show up in the medical practice, and we won't have a choice but to adapt. And that's not going to be far away as well. It's pretty soon with all the targeted interventions coming in. So that's about how the situation of personalized medicine is currently in the world. Now, if we move forward to the next one. So just to give you a simple example from, in terms of a practicing physician as to how you can use personalized medicine, these are some real patients who we were treating. So in the center, if you see personalized medicine, that has to be an amalgamation of one, the patient's lifestyle intervention, their dietary management, and on the other end, healthcare management, which is the physician. The treating physician has to actively participate in terms of their screening, in terms of their treatments. And the genomic analysis basically aids in both of them. One, in choosing the right drug at this moment, how frequently the patient needs to be screened, and what kind of diet or the lifestyle management, the screening that they should be doing based on their metabolism variants that we look at. So that the top one, I don't think you can very clearly see, I'm not sure. But anyway, I'll just tell you, this was actually one of Dr. Kalyan's patient, 28-year-old gentleman, came in with HbA1c of 8.2, was obese, and was initially supposed to be started on multiple medications because it's quite high. But when the genomic analysis was done, there were no real clinically significant mutations for diabetes. So I guess he took a chance. He didn't start him on any medications. Instead, the diet and lifestyle template was given based on the metabolism variants of the whole exome gene analysis. He monitored the patient for 4 months. The patient came back with the HbA1c of 6.6. That was without the drugs. So the patient was quite happy. I mean, he still frequently monitors, but at least he's still not on any drugs yet. So that's a big win for the patient. Similarly, the other one, she came in for cancer screening, risk screening, because she has a family history of cancer, 37-year-old lady, whose all of her first cousins, 3 of her first cousins were diagnosed with breast cancer in their late 30s. So she was quite scared. She got the genomic analysis done. It's not really to scare a person to know your cancer risk. You should be aware and try to minimize the risk. So she did have a lot of structural variants in BRCA1 and BRCA2, which are the main genes responsible, DNA repair genes responsible for breast cancer. So now she actively follows up with her gynecologist, gets frequent ultrasounds, and she's also on a very strict lifestyle management. And she's actually quite happy now. She's, I think, hitting 40, and she's been doing fine, and she's very excited and very positive towards life. So those are, again, one of them was a cancer patient who was started on a targeted therapy. I think it was probably one of the patients from the oncologist here. The other one was started on a drug because they had a mutation for PCSK9 gene. They were started on the monoclonal antibody of PCSK9, not the inclisiran, the siRNA, and they are responding well as well. So you see, pretty much genomics is coming into all of our regular practice now. This I wanted to put up because the scientific community probably know about this, but we physicians have a tough time with this one. We are bombarded with so much of information non-stop, and honestly, genomics is a completely different science. We are already specialized into something else, and it's very hard for us to again learn from scratch about everything. And when that happens, we really don't know when to figure, which genomic analysis test to order, what all do we need to look for. So this is just a very short summary. So just bear with me. I'll just quickly go over this. Maybe if you are, planning to use genomic analysis or interpreting, using personalized medicine for your patients, maybe this might come in handy. ACMG, which is the main governing body of genomics across the globe, mandates that there needs to be two-step validation to be done once you have a genomic analysis data that comes out after the sequencing. So, and that is, one of them is you need to make sure whatever data that you get from the patient, first you make sure that clinically it is validated. You should see how significant it is clinically. The first slide that you saw wherein there was like a number of 20 million, that was the validation part that we did in the last few years. We've been looking at the genomic variants to see if they are clinically pertinent at all. So that was that database that we generated, which is the first step of validation that ACMG mandates. Now that is not an easy task. It took us a lot of time because you have to go through the medical literature and make sure that there is actually evidence out there for us to use it. The second part that they strongly recommend is genomic data just by itself is absolutely useless. You can't just straight up give a patient's clinical report like that. You have to make sure there has to be a phenotypic correlation wherein you are using the patient's medical information to cross-check and their lifestyle data as well. That part is referred to as epigenetics, which is equally important. So that data must go in as well. So what we usually do is once the patient's data comes in, that goes into an initial database that we have generated. And that information we keep. I'm a member of ClinVar from the NIH as well. ClinVar is the main database which sends out the information. We correlate it with the ClinVar database. And then based on the insights that they send, we also, the data that is sent out there is phenotypically correlated as well. So that becomes robust. Now once that data feeds into the GenC database, now that goes into the next level, the second step of validation, wherein we add the phenotypic correlation. For that, we look at about 300 data points, which include the patient's serum creatinine, BUN, their weight, their medical history. All of that is given a scoring system. There is an algorithm that goes in. So that's mainly the IT department's job. But basically, all of those parameters are very important to give the final risk validation. Only if you have these two-step validation, wherever you get it from, those are the two-step validations that you have to have in order to make sure your patient's clinical report, you are able to give it to the patient. If those are not done, if they are straight up coming from the NIH databases, the results won't be accurate. It'll actually, be a negative rather than actually adding to the patient. So just watch out for that. That's one thing I would say. I think the next one, this is about the analytics part. I think Kalyan, I would want you to talk about the wet lab part as well.
When it comes to molecular testing platforms, this NGS technology is comparatively new, and it involves a lot of quality control checks. So the reason that I want to put in this slide is it is very it is dependent on the skill of the lab personnel doing the study. So it has to be done precisely and accurately, for which there are certain guidelines established by regulatory bodies, which are that we need to at least do 50 tests, and we have to show that it is same like the NABL, similar control measures which are not still regulatory, but they recommend doing this testing. So we have to do 50 test samples and then interpret the results, and it has to be reproducible mostly, and it has to be done in a same patient from 3 different samples. Once we did that, then that should be the protocol we follow every single time. The accuracy, sensitivity, and specificity of any next-gen sequencing depends on the person doing it and the protocol they are following. And they are always dependent on depth of the study. So if somebody is coming to you telling that we are going to do NGS technology, you need to understand what are the questions that you need to ask. So what are the validations done? What is the accuracy? And what are the depth coverage? And what is the size of the raw data which is coming out of it? So that is the technology part of it. I don't want to bore you enough. I think let us go to the clinical usage of this one. So this is the statistics right now. Estimated risk of 50% of heart attacks in India, and the reason that we need to adapt faster is it is 33% of the time the heart attacks in India happen at an earlier stage, and so this is the gene that they found most likely culprit. And even in our analysis in the initial data set that we have, almost 60% of the people who are having carotid disease, they are positive for PCSK9. So this, as Dr. Hima mentioned, inclisiran, which is siRNA, which just silences the gene, which is approved recently. It is not still available here, but evacolumab, which is under the brand name called Repatha, which is available here, which is available at this time. And these are the articles which shows what kind of treatments are going to come in terms of managing cholesterol and coronary disease. Next one. So ApoC3 is one other very favorite gene for most of the researchers and most of the pharma companies. So there is an antisense oligonucleotide which is first of its kind, which is already in phase 4 trial, and it is going to be approved next month, which is mRNA volanesorsen. And ANGPTL4, this is also a loss of function genetic marker. A monoclonal antibody is being developed. Next one. And the same thing with ANGPTL3. And this pharmacogenomics. So this is something which is really being picked up in Western world, and as Dr. Nima mentioned, most of the insurance companies are approving these tests because they want the outcome to be better. And every medication that we write, there is a pathway. Is it CYP4 or ULD? It depends on if you are seeing any medication which is being eliminated by liver. There are certain set of genes which are very important, and the same thing. So accordingly, for every medication that we prescribe, so FDA lists almost 581 drugs in its website which has pharmacogenes involved, and most of these pharmacogenes are actually labeled in the black label of the medications. If you look at any pharmacodynamics or pharmacokinetics of the medication, the pathway and the gene involved for each of these medications is listed clearly in them. Go to the next one. So these are the black box one. If you look at black box one, every medication that we write, there is a pharmacodynamics, and they will give what is the gene which is involved. And the guidelines are changing accordingly. Most of the American College of Cardiology and European Society of Cardiology are actively approving, accepting these guidelines. And this is what again I want to emphasize on before we conclude the session, that the personalized medicine is not going to be if it happens. So it is about when it happens, in terms of what genomics can do. And most likely these things will give us the real answers. That is the hope that why I ventured into clinical genomics, because still most of the physicians here remember the pathology examination. So if I don't know the answer, I have a standard template. First point is, it is a not so very uncommon disease. I don't even know if it is common or uncommon, but still. And then the second thing is etiology unknown. And almost always I'm right. It could be familial, sporadic, there is something like that. Idiopathy, most of the time. And then next, it could affect males and females. Of course, there is no other way. So, and I used to get marks for it and I used to pass the examination. Now I think that most of the time it is right because most of the conditions are idiopathic, and I strongly believe the answers are in our genes. The more research that we do, the more understanding that we have, then we will find the real answers and we will find the real solutions for the conditions. And coming to the solutions that we created, I think that Hima will be talking about because she is passionate from day one to build all these solutions.
Yeah, so I think we'll go over this in detail in a bit after our oncology panel discussion. But just briefly, I'll tell you, life file is basically the data of an individual that we have created, which involves their genomic analysis information, their medical information, diet and lifestyle, and it follows through longitudinally. So we are able to see how they are responding to the management. So each patient has a life file which is generated. I think later on we'll just get to see quickly the portal as well when we are launching it, just to see how we physicians can utilize that. The other one, live100.life, is basically, it's mainly for the patients. For any individual, they can just go on that site and then see what all is out there in terms of personalized medicine which is available. Also, all the physicians who are practicing personalized medicine, they'll be able to find them over there. So the doctor will also have an access through their portal. So it's basically what we're trying to do is, see, genomics or personalized medicine cannot be done just by patients separately, or the physician will also have to adapt. So it has to be a combination of both of them. So that's the whole point of live100.life. The doctor will be able to find you. The patient will be able to find you, and whatever management that you're doing, if there are any webinars that you want to conduct, there will be all that information showcased on there. So there is a constant to and fro motion. We are able to talk to the patient as well. But we'll talk about that in a bit as well. I think CRISP is mainly for the institutions to see how they can adapt to personalized medicine and not just give it to the patients, but also work on the scientific part, do some publications and just make sure that we are moving the science forward. I don't think CRISP is that much of an importance for today. Live100, we will talk about that in a bit, because I think for us physicians, that's something quite important. That's our way of reaching out to patients. So I think we'll start off with your cancer oncology panel discussion first, and then we'll talk about Live100 later. Thank you, guys.